Okay, so welcome back. Let's continue our discussion about the oral anti-diabetic drugs. According to your textbook, the 2013 American Diabetes Association guidelines indicate for the new onset type 2 diabetic that we would intervene with lifestyle interventions, oral biguanide drug, the one metformin, and if those lifestyle modifications do not and the maximum tolerated metformin dose do not achieve the recommended hemoglobin A1C after 3 to 6 months, then additional treatment would be given with a second oral agent, either a GLP-1 agonist or insulin. So since that time, we've had many medications that have been added to the mix and that have been made available to patients. And so the American Diabetic Association in 2020 has released a new set of guidelines. They're about 286 pages long. And this is just the decision cycle that I've pulled for you to see when we look at patient-centered glycemic management in type 2 diabetes, because you and I know that if the patient is not able or not willing to comply with the treatment plan, then we are just not going to get anywhere with helping this patient reach their maximum level of wellness. So we start by assessing their lifestyle characteristics. What are the comorbidities that they have? And some of the things that you may observe or notice as a nurse or know about them that perhaps they haven't revealed to the provider. Maybe there are some issues in motivation, or maybe they're having depression. What is their cultural and socioeconomic context for this patient? We can order something for them, but if they can't afford it or it's not available to them, they're not going to be able to take it. So we have to consider the things that impact the choice of treatment. We have to develop a shared plan. We have to share the decision-making in the plan. And this is where it's really important, if you're educating the patient, that you need to be educating someone who lives with them, and especially the person who cooks for them. Because if they are going to change their diet, it's imperative that the person that is cooking their diet or making their food is involved in that process and understands the gravity of what this disease can do. So we set about our SMART goals, right? Our specific, measurable, achievable, realistic, and time-limited goals. And then we would implement that plan. This is just like our nursing process, right? So we want to help our patient reach their maximum level of wellness and get to where they have their glycemic index as well as their glucose levels under control. So that's a goal of all these drugs, whether we're talking about insulin or the oral antidiabetics. But let's talk about that Biguanide. That's the one that we use, the first line drug. It's most commonly used oral drug for the treatment of diabetes type 1. Type 2. We don't use it for type 1 diabetes because insulin is the only thing that's going to work for a type 1 diabetic, right? It's called metformin or glucophage. And the way that it works is it decreases the production of the glucose by the liver. It decreases the intestinal absorption of the glucose. That increases the uptake of the glucose by the tissues. It does not increase the insulin secretion from the pancreas. And so because it doesn't increase the insulin secretion from the pancreas, it does not cause hypoglycemia, which is why it is the first choice of medication for treatment of a new onset of type 2 diabetes. Now, there's immediate release forms available and there's extended release forms available. And when this is primarily affects the GI tract, that's the adverse effects that occur with it. They have usually some abdominal bloating, nausea, cramping, diarrhea. They may feel full. It can cause a metallic taste in their mouth and also reduce vitamin B12 levels. But if you can start low and go slow, then the GI effects often will resolve. The other option, or the other thing that can happen, is if we switch them from an immediate release form to the extended release form, that also decreases the gastrointestinal side effects. So it's not always an option for patients because of insurance, but it's a really good thing to try to advocate for your patient with the insurance company if you can, to get that, because it will decrease those GI effects pretty significantly. Now, lactic acid overdose, or lactic acidosis, excuse me, is a potential complication with this medication, and it's actually pretty rare, but if it does occur, it is pretty lethal. So that's just something for the patient to be aware of in the informed consent. Our sulfonylureas, these are our oral antidiabetic drugs. We have our second generation, our Amaryl or Glucotrol or Glipizide, Glyburide, Diabeta. They say second generation, they seem so old to me now. But these drugs, they stimulate insulin secretion from the beta cells of the pancreas. So they actually increase the insulin levels. So you could have hypoglycemia as a result of that. Now, beta cell function has to be present in order for these drugs to work, obviously. So if they're not, then if there's no beta cell function, then these drugs are not going to be effective, and that patient is going to need insulin. But the drugs also improve the sensitivity to insulin in the tissues and result in a lower blood glucose level by both of these mechanisms. So adversely, we'll see hypoglycemia. They may have hematologic effects, maybe some nausea, epigastric fullness, heartburn. They have a lot of other effects, and the symptoms are actually pretty similar to the first generation sulfonylureas. The first generations, the diabinase, the tolinase, orinase, we don't see those ordered very often at all. They stimulate the increase of the pancreatic enzymes from the islet cells as well. They can also cause some liver toxicity, but these sulfonylureas, this second generation sulfonylureas, should be taken 30 minutes before breakfast. So we want to make sure the patient is aware of that. With our glinides, this is our Prandin, Repaglinide, Nitalglinide, or Starlix. This is for type 2 diabetes. The action of these drugs are very similar to the sulfonylureas, and they work to increase the insulin secretion from the pancreas. Now, the adverse effects of these drugs are headache. They can have hypoglycemia or cause hypoglycemia because they are stimulating the pancreas to release more insulin. They can also have dizziness, weight gain, joint pain, upper respiratory type or flu-like symptoms. And so some patients don't like them for that reason. We have our Glitazones or Thiazolidinediones. Yeah, that long word, Thiazolidinediones. This is Actos, Avandia, or Pioglitazone, Rosiglitazone. These are available, or the Avandia is actually only available through a specialized manufacturer program. And that, in part, is because they have been under review because of the increased risk of heart failure with the drugs in this class. And so these are insulin sensitizing drugs. They're used for type 2 diabetes. And their mechanism of action is that they decrease the insulin resistance. They're insulin sensitizing. So they decrease the insulin resistance. So we have increased glucose uptake and use in the skeletal muscle. They inhibit glucose and triglyceride production in the liver. Then we have our Alpha-Glucosidase Inhibitors, Alpha-Glucosidase Inhibitors. This is our acarbose or precose, Miglatol or Glycet. These are also for type 2 diabetes. There are some contraindications with these drugs. So the way they work is that they block an intestinal enzyme, and that enzyme is the alpha-glucosidase. So they block this intestinal enzyme, and that enzyme breaks down complex carbohydrates into simple sugars. So we would not use these in patients that have any chronic intestinal disease. We would use these very cautiously in any patient who has renal impairment. Adverse effects include flatulence, diarrhea, and abdominal pain. So if you can just think about how these drugs work, the alpha-glucosidase inhibitors, the way that they work is they're blocking this intestinal enzyme. So if there's any problem in the intestines, then we don't want to be giving this drug. They do not cause hypoglycemia, hyperinsulinemia, or weight gain because of the way that they work. And so some patients like that particularly, because patients really don't like the feeling of the hypoglycemia, and you can't blame them. With our alpha-glucosidase inhibitors, their mechanism of action, again, is that they inhibit that enzyme, that alpha-glucosidase in the small intestine. So they have to be taken with meals. Otherwise, you'll have excessive postprandial blood glucose elevations with the first bite is when we take them. So these drugs they go with the first bite of a meal. And then we have our Dipeptidase-IV inhibitors, or DPP-IV inhibitors. And these are the glipitins. So you've heard a lot about these in the recent years. Januvia, Onglyza, Tradjenta, Nesina. Notice that they all end in gliptin. And the way that these work is that they delay the breakdown of the incretin hormones by inhibiting the enzyme DPP-IV. The incretin hormones actually increase insulin synthesis and lower glucagon secretion. Thus, they reduce fasting and postprandial glucose concentrations. So with the adverse effects of these drugs, commonly you'll see upper respiratory tract infection type symptoms, headache, and diarrhea. You also may get some nausea due to the falling blood glucose levels, and hypoglycemia can occur. It is more common to have hypoglycemia if it is used in conjunction with a sulfonylurea. Now, the indications for all of these drugs are the oral anti-diabetic drugs, are that they are used alone or in combination with other drugs or lifestyle changes to lower the blood glucose levels in the patient with type 2 diabetes. These oral anti-diabetic drugs will not do anything for our type 1 diabetics, just a reminder. Then we have our newer injectable anti-diabetic drugs, our amylin agonist, that's Simlin, pramlintide, and then our incretin mimetics, exenatide or Byetta, Trulicity, Victoza, Tanzium, Adalimumab. You'll see a couple of combination agents on the market, or Soliqua and Zoltolfi. These are mixes of insulin glargine and lixisenatide and insulin digludic and liraglutide. So how do these work? Well, the amylin antagonists, they mimic the natural hormone amylin. So amylin is actually a hormone. It's an island amyloid peptide, and it is actually released with insulin. So it's co-secreted when insulin is secreted, and its job is to slow down. It helps in glycemic regulation by slowing down the gastric emptying and promoting satiety, or the feeling of fullness. So it centrally modulates the appetite and the satiety and suppresses glucagon secretion, thus reducing the hepatic glucose output. So this drug is actually used with other drugs when other drugs have not achieved adequate glucose control. It's given by subcutaneous injection. Now, our incretin mimetics, these mimic the incretin hormones, and they are hormones that are secreted by the mucosa of the small intestines following a meal. So when the blood glucose is elevated, then the incretin is signaled, they signal the pancreas to increase the insulin secretion, and they signal the liver to stop producing the glucagon. So both of these actions then lower the blood glucose levels. These drugs decrease food intake by increasing the feeling of satiety again, and they delay gastric emptying, so it slows the glucose absorption, and they're only used for type 2 diabetics. Now, this is a